Welcome everyone to this full orthodontic masterclass on anterior open bite. I'm going to take you through everything from the definition and causes to diagnosis, treatment planning, and long-term management. We'll explore how open bite affects both function and aesthetics, and how habits, growth, and skeletal patterns all interact to create it. By the end, you'll have a complete understanding, not just how to identify it, but how to think like a clinician managing it. Introducing the case. Young boy's story. Our case study today is young boy, an 11-year-old boy whose parents bring him in because his front teeth don't meet. He says it embarrasses him, especially when eating, because he can't bite into food normally. His parents also notice he lisps when speaking, and they think the position of his front teeth is to blame. He's otherwise healthy with no medical issues and no history of thumb or finger sucking. But his parents mention something interesting. His baby teeth never met either. That tells us this isn't a temporary issue, it's a developmental pattern. Extraoral findings. On facial examination, young boy shows a mild class 2 skeletal pattern. He has an increased Frankfurt mandibular planes angle and an increased lower facial height. You'll often see this in open bite cases. It's that long face tendency, where the vertical growth pattern exceeds the ability of the incisors to erupt and make contact. His lips are competent, his profile is balanced, and there's no asymmetry. No TMJ clicking, no tenderness. Functionally, he's fine. But the skeletal growth direction tells the story. Intraoral examination. Intraorally, young boy's teeth are clean, with mild gingival erythema around the incisors. There's mild spacing in both arches, and slight rotation of the upper central incisors. He has a class 1 incisor relationship, but a class 3 molar relationship on both sides. That's a red flag for vertical and anteroposterior disharmony. The key feature is the open bite itself, measured at 6 mm between the incisal edges of the upper and lower centrals. That's quite marked for an 11-year-old. Functional and speech assessment. When you have an open bite, you must assess function, specifically swallowing and speech. Here's why. If the front teeth don't meet, the lips can't create an anterior seal during swallowing. So, what does the body do? It recruits the tongue. The tongue moves forward to press against or between the incisors to close the gap, a compensatory mechanism. This is called a tongue-to-lip swallowing pattern. It's often adaptive, but in some cases it becomes primary, or what we call an endogenous tongue thrust, a habit the brain keeps even after correction. Those are the cases that relapse quickly. To assess this, we ask the patient to count from 60 to 70, or to say the word Mississippi's. You listen for any whistling or lisping, the classic sign of sibilant distortion. Understanding etiology. Why open bite happens. Anterior open bite can come from multiple directions: skeletal, soft tissue, habitual, or localized failure of alveolar development. Let's break it down. Skeletal causes. The lower facial height is so great that the incisors simply can't erupt enough to meet. This happens in patients with a downward and backward rotation of facial growth, a pattern that lengthens the face. Soft tissue causes. These are rare but involve primary tongue thrusts, where the tongue's position during rest and swallow maintains separation of the incisors. Habitual causes. This is by far the most common, non-nutritive sucking habits like pacifiers, blankets, or thumbs. A persistent thumb-sucking habit usually leads to an asymmetrical anterior open bite, because the thumb typically rests more on one side. Visualizing habit effects. When a child sucks on a pacifier or thumb for years, several things happen. 1. The incisors are pushed apart anteriorly. 2. Posterior teeth are held out of contact, preventing their eruption. 3. A posterior crossbite often develops due to cheek pressure. The longer the habit continues, the more pronounced these effects become. But it's crucial to remember, habits don't always cause malocclusion, and malocclusion doesn't always mean a habit exists. They often act together with an underlying skeletal predisposition. Prevalence and natural resolution of habits. Non-nutritive sucking habits are almost universal in infants. About 80% of babies use a pacifier in the first 6 months, and nearly 70% of children between 2 and 5 years continue some form of sucking habit. By age 7, that drops to about 12%, and by 12 years, only 2% remain. So, before you treat, you observe. Most children spontaneously stop these habits as they mature, and when they do, the open bite usually resolves on its own with growth. Radiographic assessment. Now let's move to the radiographs. A panoramic radiograph shows a normal developing dentition. No pathology, no missing teeth. Third molars are present and developing. The lateral cephalogram gives us the real insight. Here are young boy's numbers. SNA, 82 degrees, SNB, 76, A and B, 6. That confirms a mild class 2 skeletal base. The MMPA is 34 degrees, steep, confirming vertical growth tendency. Upper incisors are proclined at 111 degrees, lower slightly retroclined at 86. The interincisal angle, 126 degrees. Everything fits. Vertical growth pattern, normal incisor compensation, increased lower facial height. Diagnosis summary. So, putting it together, young boy has a class 1 malocclusion on a mild class 2 skeletal base, increased FMPA, anterior open bite, and class 3 molar relationship bilaterally. According to the Index of Orthodontic Treatment Need, this is grade 4E, because the open bite exceeds 4 millimeters. Treatment planning basics. Here's where the clinical judgment begins. Since the open bite is not due to a habit, the cause must be skeletal and functional. That makes treatment more complex. It's no longer just about breaking a habit, it's about controlling growth. The goal is to close the open bite by restricting vertical development of the posterior segments while allowing the incisors to erupt. In simpler terms, stop the molars from growing down and let the front teeth meet. Functional appliance. Approach. The appliance of choice is a twin block with posterior bite blocks. But unlike class 2 cases, we do not posture the mandible forward. Instead, we open the vertical dimension beyond normal rest height. This prevents molar eruption, while the anterior teeth are free to erupt until they contact. The muscle stretch across the mandible creates a mild, intrusive effect on the molars, naturally closing the anterior open bite over several months. It's a subtle but powerful way of using muscle balance as a treatment tool. Patient instructions and compliance. Young boy must wear his twin block full-time, including during meals. He should only remove it for cleaning or sports. Expect some soreness and difficulty speaking at first, but adaptation comes within days. If he cooperates, correction is predictable within 6 to 9 months. As always, patient motivation is the single most important factor. If habit-related, other options. Now, let's imagine the open bite was due to thumb sucking. In that case, the first step isn't orthodontics, it's behavior modification. This can include positive reinforcement, bitter-tasting nail coatings, or even fixed appliances like a palatal crib or a modified palatal arch. Recent Cochrane reviews suggest these are effective, though the evidence quality is low. Still, the principle stands. Once the habit stops, the open bite usually self-corrects over a few years. Complex and advanced treatment options. For non-habitual skeletal cases, if growth modification fails, we step into more advanced mechanics. These include multi-loop edgewise arch wires, also called Kim mechanics, designed to upright teeth and close the open bite through controlled extrusion. Temporary anchorage devices, or TADs, which can intrude posterior teeth. This reduces posterior vertical dimension and allows the anterior segment to close naturally. Always remember, posterior intrusion is powerful, but must be controlled to avoid unwanted buccal tipping or relapse. Retention and long-term stability. Once you've achieved closure, retention is critical. Retention must include posterior bite block components to maintain vertical control. Long-term, the patient must be monitored until growth completion, because any renewed vertical growth can reopen the bite. Relapse is the true challenge in open bite therapy. The patient's lisp may improve after treatment, but never promise perfection. Speech involves neuromuscular coordination, not just tooth position. Prognosis and patient counseling. For young boy, prognosis depends on cooperation and vertical growth pattern. If he wears the appliance consistently and growth remains favorable, functional treatment can succeed. But even then, fixed appliances will be needed to finalize alignment. And later in life, if vertical growth continues, surgical correction may become necessary. Summary and key takeaways. Let's summarize what we've learned. Anterior open bite is not just a dental issue, it's a facial growth pattern problem. The main causes are skeletal vertical excess, tongue behavior, and prolonged habits. Always identify the underlying driver before starting treatment. Functional appliances can guide growth, but they need cooperation and time. Relapse prevention is key. retention with bite blocks or TATE support is essential. As future clinicians, remember this: we don't just close spaces, we manage biology, behavior, and growth. That's the art of orthodontics. Thank you for watching. I hope this masterclass helps you approach anterior open bite with confidence and clinical clarity.